Good morning, afternoon, and thank you for joining us for today's VIA VitaFlow in association with you live webinar. My name is Michelle Harrington. I'm a registered dietitian on the medical and scientific affairs team here at VitaFlow North America. We're excited to bring you this educational activity and introduce our speakers. Today's topic is challenging cases in pediatric CKD. Please note, this program is being recorded. Support for this presentation was provided by VitaFlow North America, a Nestle Health Science company. The views expressed herein are those of the presenters and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented. It is for educational purposes only and is not intended as a substitute for medical advice. Please note, questions will be addressed following the presentation. However, you are welcome to submit text questions into the question and answer pane at any time during the program. If you have any questions relating to VitaFlow product or any of our resources, feel free to contact your VitaFlow representative following the program. You can access a PDF of the slides in the chat. This program is not eligible for continuing professional education credit. Now I have the pleasure of introducing our speakers. Christina Nelms is a registered dietitian with over 20 years of experience in pediatrics, primarily working with renal patients. She's held several clinical positions, most notably at Children's Mercy Hospital and clinics in Kansas City, where she currently works. Christina has been involved with speaking and educating at local, regional, national, and international professional renal meetings, as well as authoring 3 book chapters and other publications. She is also a member of the International Pediatric Renal Nutrition Task Force, whose main goal is formulating clinical practice recommendations to enable best practice in the nutritional management of children with CKD. She has been instrumental in setting up and leading the Pediatric Renal Dietitians of North America group, also known as PRONA, which is the first professional practice group aimed at serving as the leading source of pediatric renal nutrition expertise in order to improve patient outcomes and promote community and networking amongst pediatric renal dietitians. Lisa Kyung is a dietitian who cares for children with kidney disease. She previously covered outpatient pediatric CKD, dialysis, and kidney transplant, but has shifted her primary focus to CKD and dialysis. Lisa earned her bachelor's degree in nutrition at Case Western Reserve University. She completed a master's degree in clinical nutrition at the University of Memphis. She is a certified specialist in pediatric nutrition, and Lisa is also a member of PRONA. She has published a chapter on nutrition in adolescents with chronic kidney disease and case reviews in advances in peritoneal dialysis. In her free time, Lisa enjoys traveling. Her favorite destinations so far have been Japan and Spain. She has an adorable young daughter who keeps her on her toes, teaching her patience and helping her to be a better person. Jessamine Newcomb is currently a registered dietitian at New York Presbyterian Hospital, Morgan Stanley Children's Hospital, primarily working with pediatric CKD, dialysis, and renal transplant. She earned her bachelor's degree in dietetics at the University of Delaware. Jessamine has been an invited speaker presenting on topics such as CKD and pediatric nutrition and pediatric transplant nutrition. In her free time, she likes to cook and spend time with her dog, Dylan. At this time, I'd like to hand it over to Christina.
Thanks, Michelle. I'm going to just, I am doing this part because just to glide right into the webinar, but just introducing for our sponsors today, VitaFlow, their renal products, which include RenaStart and RenaStep. I like to call Start, the one that you use when you need the most flexibility, and Step, the one that you use when you need the most convenience, because Start is powder and can adjust feeds more easily, where Step is a drinkable, convenient, all ready to go liquid formula. So similar products to use for the management of CKD and dialysis patients. It's important to note that Start and Step are altered and renal specific nutrients. This is intentional to allow low levels of these nutrients that are often need to be limited in CKD and dialysis patients. Of note, potassium and chloride are especially low because they are designed to mix with other formulas. It's not a standalone product. The goal is to make a custom formula with a custom amount of potassium and chloride to manage bicarbonate levels for children with CKD. And the goal is that you do not need to use a decanting product like sodium polystyrene sulfonate when you use a product like Start or Step. So we are going to jump right into the first case study, which is mine, regarding an adolescent with refeeding syndrome. So my case actually came to me when I was covering a general floor of my hospital. So it's a child that had kidney issues, but was admitted to the general inpatient unit for weight loss in the setting of chronic diarrhea. This kiddo had a history of CKD stage 2 that had been managed by nephrology related to neurogenic bladder and associated issues, as you can see his background there. Importantly, he had some additional issues, seizures, but the important two for this case being ADHD and ODD, or oppositional defiance disorder. So he had lost weight so quickly, and between the diarrhea and the not eating, he had some AKA on CKD, which basically means you have some acute kidney injury that worsens existing chronic kidney disease. So it was estimated, once his AKA was managed, that this acute hit had basically taken him from CKD stage 2 to CKD stage 3 permanently. So his AKA was highly dehydration related, so pre-renal injury. Importantly, he had lost 20% of his weight in a 4-month period, and he didn't have that weight to lose, as you'll see his growth charts here in a second. And the big concern with his initial admit, the thing that we are most concerned about managing, was the risk of refeeding syndrome. So this is a nutrition diagnosis. I gave him acute severe non-illness related pediatric malnutrition because of inadequate energy intake. And I noted his BMI score, but if I had to do it over again, I actually would have probably noted the extreme weight loss. So obviously I had more growth data plots than this, but I wanted to just paint a really clear picture for you guys. So I've included select plots from early plots showing that his linear growth has been affected by CKD, but also likely due to his inadequate intake. His weight also trended along the lower lines, and this is where you can see his rapid weight loss there at the end, and of course his BMI was affected. So some additional information. He came in, nephrology already had him on iron. He was put on IV fluids because of the diarrhea. And I'll talk about this a bit more in a second, but during the initial phase, we added a multivitamin with mineral, thiamine, and vitamin D. His diet, he had previously been on some potassium and phosphorus restrictions, educated on an outpatient nephrology basis. His potassium was an initial issue. It had kind of resolved, but phosphorus, because of an elevated PTH, had been more of a recent issue. But the team, we decided to not do any diet restrictions because of the severity of his food and nutrition issues. So he came to us, he was only baseline eating about 400 to 500 calories a day, we estimated, and that was mostly crackers, especially saltine crackers. So not a lot of good nutrition there. His baseline needs I estimated at 1600 with a goal of 2000 for some catch-up weight gain, DRI protein because of his renal issues, and then nephrology had previously given him a 2-liter fluid goal. So his labs, I think, were what were really interesting about this case. Obviously, he came in with an elevated BUN and creatinine. The BUN was the especially elevated one, consistent with pre-renal AKI. His phosphorus, he came in with a pretty elevated phosphorus. It stayed elevated. We did have some improvement by discharge. He was initially a little acidotic, and this was the 111 was actually lab before he was admitted, but he stayed on the low end of normal to a little bit low for a nephrology patient. During admission, we did get him to a normal bicarb by discharge. Magnesium, you'll notice I didn't have those labs right away at the beginning of admission, but those were low. His potassium actually stayed in the high fours, a normal range during his admission. And a couple later labs I wanted to point out, his phosphorus eventually did get to a normal level as well as his bicarb. I wanted to highlight the phosphorus and magnesium because those are kind of kickers of this case, as we'll get into. So knowing this background, and I've already given you a little preview of what we're going to do, what would you do for this patient? And you can pick more than one answer. Do we have a poll ready for this, Michelle? Start a phosphorus restriction, start tube feeding, encourage diet with favorite foods and no diet restrictions, start an oral nutrition supplement, or start a multivitamin. What would you have done? Okay, 10% start a phosphorus restriction, 28% would start a tube feeding, 56% encourage diet with favorite foods and no diet restriction, 54% an oral nutrition supplement, 31% a multivitamin. So I see a good mix of answers, which speaks to the fact that this was a tricky kid. It wasn't always clear what we should do. And I think your answers reflect that. So what we started with, and this changed during admission, but my initial recommendations, I was very worried about the refeeding. And keep in mind, I didn't have the magnesium levels yet. So we started a general multivitamin. I was concerned because they felt that he was at stage 3 CKD, but with that refeeding risk, I felt that we had to address that first. So we did 5 days of a general multivitamin, at which point I suggested we switch to a renal multivitamin. Thiamine is really important for kids with refeeding. Some of these nutrients, thiamine being a big one, when you're malnourished and we start to feed you, cardiac function is high in demand for these nutrients. So our standard refeeding protocol at our hospital, which we tend to use more in our eating disorder patients, but this patient, as well as children who come from abuse, neglect situations, is thiamine times 5 days. So that's our standard protocol. I had recommended 75 milliliters an hour continuous, and we did continuous because of the diarrhea until they got that under control, noting that I wanted a goal of 1,800 milliliters, eventually divided into bolus feeds, which we kind of changed course on that, which I'll explain. I was concerned about that elevated phosphorus, but I was concerned about refeeding syndrome. So we did a little Rena step with some Ensure, so I could reduce his phosphorus a little bit, but I didn't want to be too aggressive. And then I requested we monitor labs really closely, which then we did, and I got helpful data. So we did a calorie count, and he was eating very little on day 1. Now we did add the tube feeding, but he also picked up more oral intake on his own. So I think he and his family realized how seriously ill he was and were more motivated to change that. We decided to add some Renvela with meals instead of limiting his diet. And I discussed with the physicians that we could increase the Renvela if appropriate, but I didn't want to restrict his diet. We added some sodium bicarb, and I know with the bicarb of 20 to 22, that's sort of low or low normal. We consider 22 the goal for kids with nephrology, but given the history of malnutrition, and poor diet and poor growth, I felt like we should really optimize his bicarb levels. And then we again switched him to a renal multivitamin eventually, and importantly added some magnesium gluconate once we started seeing those low mag levels. So here is the real kicker of the case and what I wanted to discuss and get your thoughts on next. As I mentioned before, he had oppositional defiant disorder, or ODD, as well as ADHD. And he had been frustrated about his renal diet restrictions. I'm not saying they weren't appropriate, but he acted out against those and he started using food as control. He had basically just refused to eat because he was told he had to do these diet restrictions. That was his form of control and defiance. He wasn't honest about what he ate, and this is all according to mom's report. Food was a big deal in their house. So almost an eating disorder type picture, but more related to the ODD. Mom reported to me that dad was very traditional, conservative, you eat what's on your plate. And that was a huge stressor. So food and control issues really abounded in this home. Mom herself was post-gastric bypass surgery and very familiar with food and calories and what comprised a portion, which is important because of what we eventually felt like we could do with this kiddo. But at this time, I'd like to ask what you would have done or what you would consider doing next with this patient. So we have changed to bolus tube feeding, encourage oral diet with oral nutrition supplement, discontinue tube feeding and educate on low potassium and phosphorus diet, or a psychology consult. And again, I think you can pick more than one answer. Change to bolus tube feeding, 35%. That was my original plan. Encourage oral diet with a supplement, 57%, discontinue tube feeding and move to a low potassium phosphorus diet. I will say this is what happened more long-term, a psychology consult. So I threw a psych consult in there, even though we didn't actually do that because he was already heavily followed by psych. But I think that if he had not been heavily followed by psych, that would have been really important. So I'm glad a lot of people picked that. Okay, so moving on. So I know this slide is a little busy, but it is important information for the whole picture. What we decided to do, since mom said he was more of a snacker than a big meal eater, is we kind of set up a structure, and it also worked out a little easier for the math this way. And since mom was very familiar with calories and what would equal 400 calories, what we decided to do is make a goal of 400 calories for snacks and 400 to 600 calories for meals. We assumed that between in between snacking of the crackers he would often eat, it was probably getting 400 to 500 calories baseline. And I wanted a minimum of 1,600 calories, a minimum to meet his needs. And then whatever he got beyond that would help promote the catch-up growth. So our plan was to structure 3 meals into what I call hearty snacks, or 400 calorie snacks. So the plan, and this was developed really thoroughly with mom, she had a lot of input, is up to 4 bottles of Renastep per day, which, as you probably have done the math, that is 1,600 calories, which was his baseline need. So 1 bottle would replace 1 meal or 1 snack. And again, we assumed he would get in at least 1 snack a day. So in the hospital, we were initially doing a rate of 70 mils per hour. So we kind of use that as our baseline. And I used it as my example when we started. Because mom was really, again, good with math and calories, we gave the management to her. That at home, she could speed this rate up or start earlier if he needed all 4 bottles, for example. This also helped break down some of the control issues. So we tried to reverse where this child had the control. The idea was that if you eat, you don't have to have NG feeds. And if you eat more, we don't have to ruin your night by starting at 8 or 9 p.m. at night. We can start at 10 or 11 o'clock at night. So for example, the day that we started this inpatient, he had eaten 2 meals and 1 snack. So that night he got 2 bottles of Renastep, and mom paced the rate appropriately. And the Renastep was nice because it's super compact in terms of volume. So really handy for that. Pretty much we assumed that unless he was at home on the weekend, he was going to get at least 1 bottle of Renastep during the weekdays, because we couldn't trust that he would eat lunch. And hopefully with psychology, at some point this could be changed. And he was often telling his mom that he would eat breakfast at school and then not, as an excuse to not eat breakfast at home. Additionally, sometimes his breakfast would be a banana, which isn't a full 400 calories. So we would count that as half of a snack. And mom really embraced this plan, and this was very individualized. So it worked out for them. So in terms of outpatient follow-up, I had offered to have this mom contact with me until she could get set up with nutrition with outpatient nephrology. And she did let me know that it was going really well. She did have to set an alarm because sometimes the patient would turn off the pump if an alarm went off and not get his full feed. But otherwise, it was really kind of reversing some of those control issues. And upon review of the chart seen by his outpatient nephrology dietitian months later, he was still struggling to gain some weight, but the Renastep was going well, so they added another bottle, mostly as an oral supplement as opposed to the long-term NG feed. So this worked really well for this patient and the behavioral component of his feeding issues. So now I would like to turn it over to Lisa for her case.
Thanks, Fritz. That was really informative, and I love the questions on the polls. So I'm gonna talk about an adolescent with avoidant restrictive food intake disorder, also known as ARFID. And just to give you a brief introduction of my patient, CC is now a 14-year-old male with a history of chronic kidney disease secondary to posterior urethral valves. He also has polyuria and history of hyperkalemia. He came to us from a different institution in 2017 because I think he moved to Northern California, so transferred his care to us, and that's when I started seeing him. Over the years, his kidney disease advanced, and he eventually was started on peritoneal dialysis in 2022. And then about a year later, he had received his deceased donor renal transplant in September. The big things that we tried to intervene for nutrition was to support him with an appetite stimulant to encourage him to eat more by mouth. We managed his G2 feeds in terms of adjusting for the timing and the type of formula to provide to supplement his oral intake. And then ongoing counseling in terms of food choices to correct his electrolyte abnormalities. Unfortunately, of course, we had barriers throughout his course. Part of this was just family having poor follow-up care, just not coming to clinic visits during his CKD. And then there were financial difficulties that weren't communicated by family that resulted in the vendor not being able to consistently provide the formula to the family. And then there were some behavioral issues specifically on the patient that caused inadequate nutrition. So to just give you a timeline of how we managed his enteral nutrition, as he came to us in 2017, he was on Soplina with dual cal that provided about 33% of his energy needs, and then again the rest was by mouth. He did require KX late despite being on a lower, like a renal formula with lower potassium. And so since he was tolerating okay, we just maintained him on that. And then it was about a year later that we then saw him again and recognized that his intake wasn't good, that he was continuing to have poor waking. And so a lot of it had to do with some GI symptoms that he was expressing and early satiety. So one way to kind of help with that was to switch him to Arena Start, because our thought was that the KX was bothering his stomach. And we knew that Arena Start was a lower potassium option than Soplina. And so we were able to stop the KX, give him a similar caloric intake as Soplina plus dual cal, at a 1 calorie per ml concentration, because again, like he just wanted to drink so much, and like the way that the feeds were, we didn't want to keep making multiple changes and recognize that he might not tolerate. So we just kept everything the same except switching out the formula. So over the next few years, he actually does really well and gains weight appropriately. But towards the 2020 to 2021, we start to see weight gain drop off. And so the barriers at that time were early satiety from like his desire to drink water, ongoing poor appetite with his worsening CKD. And then there was a question of how accurately the parents were mixing the formula. So again, we're trying to fix one thing at a time. The main thing was because we weren't sure parents were mixing it correctly, and then the feeds were being changed based on tolerance of the patient's report, we said that we would switch to Arena Step, which was like ready to drink, so that like there was less preparation involved, and it was a more concentrated mixture than what we had with the Arena Start. So from there, it seemed like he was doing well, but then as we follow up with him in June, as he's about to start peritoneal dialysis, there's a communication issue with parents that like the vendor had not been supplying the correct formula, that they had sent Rena Start instead of Rena Step. And then once we corrected that, then it happened that the parents weren't, they were behind on their payments. And so then they weren't getting the formula as expected. So all of this came to light when they started dialysis. So at that time, since we knew that he was going to be on daily dialysis and potassium wasn't going to be an issue, we went back to Soplina just to clarify the issues with the vendor. And the next couple of slides, it's really just to kind of give you an overlook of how he's eating and how it changes over time. He generally, big picture is that he's eating pretty regularly, 4 to 5 small meals a day. And you can see that there's a variety of different foods he's eating, including fruits and vegetables throughout his time. And a lot of choices are pretty high calories. So again, it's reassuring that he has a good intake when he has a good appetite. As we're getting into 2020, to 2021, again, he's still doing the 5 small meals, but we see that his food choices start to drop off dramatically. And he's really just eating kind of the very neutral, bland foods. And then by, like I said, June 2022 is when he starts peritoneal dialysis. So again, in general, there's a very, he is like restricting his own food choices. So what does it look on his growth chart? This is a representation of his weight over time. You can see that the arrows show you like when he was on Soplina, how he was doing, and the asterisk marks are when he was at an outside institution. The black dots are the weights that we get at UCSF. So in general, what we're noticing on this diagram or growth chart is that he is gaining weight on the Soplina, but then it does seem like he's starting to slow down, and that's when we start the Renastart to try to get him to catch back up, because he previously did track along the 25th to 50th percentile. So over that course of the few years, he does start to actually do the catch up that we expect. But then like from 2020 to 2021, we see that he completely levels off, has very minimal weight gain and even some weight loss. That's when we start the Renastart. And so he does show some improvement, but then levels off because, again, all those other factors that I had previously mentioned. And then because of his advancing CKD, he has started on dialysis. And so we move him over to Soplina just again to clarify some of the concerns that the parents were having, and to maximize his enteral feeds. Even despite that, he does show improvement in his weight, but then it levels off again. And I think this is where we want to talk about really is why is this happening? And before we get into that, this is how his growth, linear growth is looking. So at age of 3, he's less than the 3rd percentile, and he starts growth hormone at his outside institution, shows catch-up growth by age 5, so they stop his growth hormone. But he continues to grow steadily, and even crosses the percentile channels back and getting closer to his genetic potential. So he's tracking around the 25th percentile. And as he transitions over to us, he's still tracking at the 25th, but then as we see this inadequate weight gain, it starts to slow him down in terms of his linear growth. I think this is an outlier based off of like, as we see his future trends. And so what happens is he is in his pubertal stage, and he has his growth spurt. Again, not showing his linear catch-up growth to his genetic potential, but it is past what he previously was tracking along. So now he's closer to the 50th percentile. And then because of his ongoing poor weight gain with his advancing CKD and starting dialysis, we see that his poor weight gain has really likely caused him to have stunting of his linear growth. And to really bring that home is looking at his BMI. So even right before he starts PD, right, we talked about how he wasn't really gaining weight, and you see his BMI drop 2 percentile channels, so already indicating he has some malnutrition involved. And so despite our best efforts to maximize his enteral nutrition and to discuss his oral intake and counseling, we really don't get that great of catch-up growth to get him out of malnutrition. Best is like mild malnutrition. So the meat of this story, right, is to talk about ARFID and how I started to think about if this is playing a part in his care. In general, it was more about the discussion of like, as we're trying to maximize his oral intake and to incorporate more variety, it was reported that, like, you know, for a particular mac and cheese that he enjoyed, he'd only eat the single serving per prepared one versus eating the box one. So it'd be the exact same brand, prepared the exact same way, and it could even be presented in a single serving. But if it wasn't actually made in the single serving, he would refuse to eat it. He would like corn dogs, but never eat the corn dog itself and just eat the breading. So he talked about like, okay, well, if you like cornbread, let's like make the cornbread alone. And then like from there, we can always like add more calories. Again, he refused based off of like just how it looked and wasn't sure about the taste. And so refused to like try that. And it continued with all these different things that we like associated with it. So instead of like bagel bites, we tried regular pizza. He consistently enjoyed his like gummy snacks, but only this one particular brand. He would not try any other flavors or textures of any other brands. And then the big one that like really caused me to think twice about talking about this a potential ARFID diagnosis was he enjoyed cheese, and it, again, one of the things that he consistently enjoyed eating, but he only wanted it shredded, and it had to be a block cheese that mom would shred herself, that he would eat it. If it came from a bag of shredded cheese, he would refuse. Or again, like if we tried like slices or chunks or strips, he again would just refuse to eat it completely. So it had to be on mom to like prepare certain things for him to be willing to eat. Then there is this ongoing abdominal pain when he would eat certain foods. And it could be the same foods that he enjoyed, and he would still complain at times. A lot of it had to do also with like the timing of enteral feeds, that he would say, my stomach hurts, I don't want this right now, or maybe mom would get through like a couple boluses and then he would just refuse to take any more. There's never a report of any food insecurity, and patient always wanted to like gain weight, he wanted to grow, and so there wasn't an issue, or when we assessed him for any body image dysmorphia, that it came up positive. So that wasn't one of our issues with him. So I'm just going to talk about like what an ARFID diagnosis looks like and how it would get managed. So ARFID is an avoidant behavior that's related to the lack of interest in eating. It's avoidance of sensory characteristics of food, and it causes aversive consequences to eating, which then leads to deficiencies in macros and micros that then either cause a significant weight loss, significant nutritional deficiencies. There's a dependence on G-tube feeds, or it can also cause marked interference with their psychosocial functioning. Again, it's ruling out like that, like food availability is a reason, or religious or cultural food practices are a factor in that. It doesn't have to exclusively occur with anorexia or bulimia, and it's not a result of abnormalities in their experience of body shape or weight. And it cannot be explained by their current state of health or co-occurring mental disorders. So looking at this type of definition of like how to diagnose ARFID, I think it's hard looking like in the moment in time trying to diagnose it. But in hindsight, it's like, okay, I can recognize like there's certain behaviors that he's making in terms of his food choices. The fact that like he has this advancing CKD could be part of the reason why he's choosing not to eat certain foods, and that's part of why his weight loss. So it can be a very difficult thing to diagnose, and I think it takes time to recognize that. Part of the management of ARFID is like having a set team that includes a doctor, a dietitian, an eating or feeding disorder therapist. And if someone has dysphagia, then a speech language pathologist should also be included. The role of the dietitian is really to focus on their anthropometrics and make sure like that we're meeting our goals. And then assessing their nutritional status. So if they're restrictive in certain foods, then we want to analyze what micros or macros they're missing. And when we start to do this food chaining as part of their therapy, is to identify the foods that should be introduced first to maximize their nutritional status. And so, like I mentioned, there are like food chaining is a therapy, but there are also other therapies that can be done at the same time. And so to go over them briefly, food chaining is where you introduce new foods that are similar to the already accepted foods. So we don't want to introduce brand new foods to them when they're not even ready in their mindset to try new stuff. We want to just start like very slow and steady. And a lot of this is like a discussion with the patient and then holding them accountable to the decision that we make together. So an example is like if they only eat whole strawberries, is can we do sliced strawberries, then work to jam and then dried strawberries? And it doesn't have to be in that specific order, but again, like that conversation should be had with the patient and decided together. And then the next step or congruently happening is the feeding and body investigators, which is also called FBI. And it's really addressing the anxiety and the GI disorders related to ARFID. So as they're being like introducing these new foods, then we want to like talk about like how does it make them feel? If there's negative associations, can we address it by, changing the perspective and making it more positive? And if it's in a young child, then we're doing it through play. With older kids, it makes it that much harder. And so, but there are methods for them to manage that. And then we want to bring the family and get them more involved in the patient's care. And part of that is also making sure that the parents aren't blaming or feeling guilty about what the diagnosis is, right? It's moving forward and helping them with their child to address the issue at hand. And the other thing is to, again, continue to keep introducing these new foods. The last therapy is called cognitive behavioral therapy, CBT. And so this one should be done only in outpatient with kids older than 10 that are medically stable and not receiving any G-tube feeds. And the sessions really depend on the number of patients, the number of sessions really depend on your goal for weight gain. And then there are 4 stages to that. The first 2 stages are really focusing on advancing the diet. So again, using all those other previous therapies that we're talking about. And then in stage 3, again, some of the harder ones we might be doing in clinic and working through it by using the FBI therapy with the patient. And then 4 is like, as they're progressing, we really want to make sure that we have a plan in place for any potential relapse. So now that we have a better understanding, hopefully, of ARFID, how would you guys approach this ARFID diagnosis with the family? So people chose all the above. I agree. I think that we really want to present a united front to the family and go over like what are the signs that we're seeing, and discuss that it's not the patient's fault or the parents, but that it is something we need to address. So thanks for that, everybody. So this is what I did. I talked to the parents. They acknowledged it, but recognized that they're going through a lot. They really weren't ready to like officially see somebody to get this diagnosis. And so they wanted to wait and just keep working on it. I think I would have, and what I would have done differently is like acknowledge how they're feeling and really bring the team back in with me and kind of express like it is overwhelming diagnosis, but like there's consequences long term that affect his quality of life and his ability to keep managing, and it only makes it more difficult if we prolong not managing it, right? And maybe even just kind of giving them a basic outline of like what the treatment plan could look like, and so that would involve just getting, again, maybe a referral to the eating disorders team. So what foods would you include in food chaining? And you can choose a variety of different ones if you want. Yeah, so I love that it's like a variety of mixed answers, because it's not that simple. And so this is what I did. I focused on cheese because, again, we were talking as a family and specifically honing in on the patient about like how to try to start this food chaining. And I didn't call it food chaining. I just said like we're trying to expand. And so he felt like cheese was the best one. He continued to refuse to eat it if mom didn't shred it. But then mom got sick one month and said, like, if you want to eat this, like, you're going to have to do it. And so instead of him shredding the cheese, he decided it took too much time. And so he cut it into cubes and ate it. So when that information came back to me, we were being positive about like how great it was that he did do that, even though it wasn't in the best circumstance. But we talked about like also just instead of just being like positive about it, is like I should have spent more time with like, how did that make you feel? Was there any like negative feelings associated with that? And if there were, like, could we like change the perspective, right? And think about like, okay, how did you tolerate? How did it feel? Like, it felt okay. And then like thinking about like, what did that do for you, right? It expanded your diet and so on. So I think I could have taken it to the next step, with having that, with having him make that exception. So in conclusion, I think identifying ARFID takes time. Part of that is making sure that you have the right tools and know like what the signs of for ARFID is. And so if you do need a tool, there is the 9-item avoidant restrictive food intake screening. So you can use that in your back pocket if you start to suspect it. And I think the other thing is just making sure that like your team is aware that like a lot of these kids with chronic illnesses are probably more susceptible, especially when they have poor nutrition at a very young age and are requiring supplemental G-tube feeds, or any kind of enteral feeding, because it really impacts their ability to meet their developmental milestones for advancing their oral intake. And so just again, like, I think that ongoing education with your team members and then having a standard approach in terms of talking to your patients and their families about it can help a lot of our families that are experiencing this and get them into the right therapies to at an earlier stage, to helpfully resolve the issue sooner rather than later. So I'm going to turn it over to Jessamine.
So for my patient, talking with a child with end-stage kidney disease. So XS, she's a 4-year-old X35 weeker. She has end-stage kidney disease due to left multicystic dysplastic kidney, right renal dysplasia. She also has abnormal GI-GU anatomy, hypothyroidism, anemia, and metabolic bone disease, hypertension, and she has been on peritoneal dialysis since 2 weeks of age. Some of her meds include amlodipine, enalapril, calcitriol, calcium, iron, epoetin, and the liquid renal multivitamin. Some of her other issues include poor weight gain, failure to thrive. She has a history of needing an NG tube, not adherence to meds and diet, and some oral aversion. So I met her in December of 2020, but I wanted to give some background information. She was on Similac 60/40 decanted with Kexlate, with sole carbon MCT oil added to increase her calories. In August of 2020, she didn't receive most of her NG feeds because there was an NG supply back order. And then in September, her NG was removed during one of the clinic visits and it was not replaced. Mom was really not amenable to replacing it at that time and wanted to kind of optimize her PO as much as possible. In October, she had some poor weight gain, so her recipe was increased to 37 calorie per ounce by adding more MCT and sole carb to avoid changing like the decanting recipe. And then in November, she continued, with poor weight gain, some weight loss. So her recipe was again increased to 40 calorie per ounce. And that time, Kexlate was adjusted because the recipe went up in the Similac PM content. And in December, she ended up not tolerating the higher Kexlate dose. She had a lot of vomiting, and mom ended up going back to the lower Kexlate dose, and she tolerated it fine. So no vomiting, and her labs looked okay. So we just told her to continue that and see how she did. This is her weight for age growth chart corrected up in that point. So you can see the moment her NG tube came out, she really started to fall off her growth curve. She had about 50 grams of weight gain over 3.5 months, so very low compared to what we expected, 4 to 9 grams per day for her age. So I see her in April. She has ongoing feeding therapy with a speech therapist. She was getting early intervention, eating some solids and snacking throughout her day. She liked vanilla wafers, cheese puffs, powdered donuts, and then she continued with her pureed food. So mom said like full baby food jar of like 2-3 times a week. She continued with on the decanted 40 calorie per ounce formula, and she was getting about 100 calories per kilo, about 1.6 to 1.9 grams per kilo, just from formula alone, based on like what mom told us. For her growth is getting a little bit better. She's gaining about 7.6 grams per day, so a lot improves compared to before I met her. And then We get her labs after that visit, and her phos is 8.3, and her calcium is up to 12. So at that point, her doctor decided to start sevelamer packets, 400 milligrams, 3 times a day, and then hold the calcium. We didn't do any formula changes at this time because she's finally gaining some weight. We see her a few months later. In between visits, she really didn't tolerate the sevelamer packets. She had a lot of vomiting, and I also tried to reinforce a low phos diet. As far as intake, she remained on the decanted 40 calorie per ounce formula, but her intake has decreased, a little bit since last visit. There was a report from mom that she has no changes to what she's eating, but limited information was provided to us. As far as weights, she lost 75 grams over the past 3 weeks, and she also had some decline in weight for age and BMI for age Z scores. We get labs then, and her phos is even higher at 9.5. So what would you do in this situation once you get those labs? So for the choices, try Renastep. 60 calorie per ounce, decanting is not needed. Can watch formula tolerance, no changes, and reassess weight next visit. Dilute Renastep to 40 calories or cut the sevelamer dose in half. Reduce the calorie density of Similac 60-40, and increase the modules to stay at 40 calorie per ounce. All right, so mostly the first one, so try Renastep 60 calorie or dilute the Renastep to 40 calorie per ounce. So what we ended up doing, since she had some vomiting and she had some weight loss, for her doctor, we didn't switch her formula at that time. We ended up trying to decant her formula with sevelamer and see how that went. And then mom wasn't amenable to trying Renastep, so I had samples sent to her, and then the plan was that if she liked it and tolerated it, to hopefully switch to that and switch next visit. So a few months later, we see her, she's tolerating the decanted formula with both Kexlate and sevelamer. Her formula intake did decrease even more compared to the last few visits. She did try the Renastep and she liked it, tolerated it. Unfortunately, she continued with decline in weight for age and BMI for age Z scores, but there is some improvement in weight gain since stopping the sevelamer by mouth and putting it into the formula. We get repeat labs. Her phos is a little bit better. So it went from 9.5 to 8.6, but it's still, pretty high for her age at this point. So our plan was to slowly transition to Renastep, dilute it if unable to tolerate the 60 calorie per ounce. And we gave her a goal to do 250 mLs a day or 500 calories. Plan to increase as tolerated to get her to gain a bit more weight. And then we sent a script for 2 bottles a day. We see her like a month later. In the meantime, mom has told us that she's doing well in the Renastep. She's drinking 400 mLs per day. And then in between visits, mom called the clinic and that she was running out of formula. So this script was increased. So at this visit, mom reports no changes to her usual diet, but she was sick and had a lot of vomiting recently. So it was a little bit down compared to usual, but this time she's eating back to normal. For formula, mom said she's drinking 4 bottles of Renastep a day. So that gives her about 150 calories per kilo and about 3 grams of protein per kilo. Her weight trends, her Z scores are stable, and she has had ongoing improvement in her weight gain. So that's at least great. We get her labs back, and her K is down to 2.9. Her BUN is almost double to 85, and her phos is back up to 10.8. So what are our next steps? So no change in formula since improvement in weight gain, decrease amount of Renastep to lower protein intake, switch to a lower protein formula, increase hydration, and ask the doctor if her PD can be adjusted.
I'm going to give them a minute. They're coming in quickly. Okay, share it.
Let's see. So top 2 was switch to a lower protein formula and ask the doctor if PD can be adjusted and increase hydration. So here's what we did. We decreased the daily max of bottles of Renastep to 2 bottles a day. So that would hopefully lower her protein to 1.5 grams per kilo compared to the 3 grams per kilo. And her protein needs at this time is about, like, estimated needs would be like 1.2 to 1.35 grams per kilo. We did start a potassium supplement. We kind of deferred liberalizing her PO diet and her restriction at this time because of her history of non-adherence to her diet recommendations. Her PD was adjusted, so it increased the fill volume. The KT/V was below anyway, so that was adjusted, and then repeated labs in 1 week. So in the next few months, just kind of summarize it, mom really struggled to limit her Renastep to about 2 bottles a day. She ended up having some hypernatremia, so the doctor recommended to increase her water from 100 mLs to 200 mLs per day to hopefully help with the hypernatremia and the increased BUN. We also tried diluting the Renastep back to like a 40 calorie per ounce to see if that will help her excessive intake at that point. She did end up having some elevated potassium levels, so we decreased her K supplement by half in mid-November. And during all this time, her PD prescription was adjusted again twice. So in December, we see her, she continues with good weight gain. Her weight for age Z-score is stable, but she continues to drink more than 2.5 bottles of Renastep per day. She didn't really like the diluted taste. We tried to really encourage, solids, attend and discuss, low phos foods as much as possible. Her labs came back in December. Her K was 5.7, so quite high. Ended up discontinuing the potassium supplement at that point. Her BUN was still pretty high at 75, and her phos was also uptrending, so it was now 7.5. So we see her for a video visit in mid-January. Here are her labs. So her K is back down to 2.9 after discontinuing the supplement. Her BUN is higher at 84, and her phos is a little bit better at 6.7, but still pretty high. So what changes can we make at this point? So what we ended up doing was the doctor restarted the potassium supplement. We decided to switch to Renastart to decrease her protein intake. And our goal was 400 mLs of 400 mLs of the formula per day, and that will take her protein from 1.5 grams per kilo to about 1.1 grams per kilo. And I gave mom mixing instructions to give exactly 400 mLs per batch, and then to continue the 200 mLs of water. So we see her next month. Mom tells us she initially didn't like the Renastart to 60 calorie per ounce, but we tried adding vanilla extract, and she ended up really liking it and drinking it really well. Reports that she's taking the 400 mLs and tolerating, no issues. She continues to eat her usual foods. Mom says no change in her diet, but again, limited information provided to us. She's had some weight loss in the past 4 months, and then she had also some weight for age Z-score declined by 1. We get her repeat labs. Her K is finally okay at 3.7, so we're at a good place. BUN is back down in the 40s, and her phos is 12. So what is our plan? So per MD, we're going to try to restart her sevelamer packet, 800 milligrams twice a day, and we're not changing her formula because her BUN is finally in a better spot, and we've had enough of the formula changes the past 6 months. So after all that, where are we now? In March, she ended up transitioning to hemodialysis 3 times a week. During that admission, we discontinued the K supplement and we liberalized her diet. We figured, well, she's in our hemodialysis unit, we can actually get labs and monitor it a little bit closely. So we thought that was a good idea. And she didn't tolerate the packets again, but we ended up switching it to the suspension form, and she did just fine with that, and her phos has improved to around 6. She was fluid restricted to 700 mLs per day, but we actually ended up increasing her formula goal from 400 to 500 mLs per day, to give her, hopefully help with weight gain. In April, she had low BUN with dialysis. So we tried concentrating her formula to 65 calories per ounce because if she had a pretty strict fluid restriction. We didn't switch back to Renastep given she had this history of excessive intake. And in May, she continued with the low BUN. Mom was amenable to trying to increase her formula to 600 mLs and kind of leave her with 100 mLs left for other fluids. And then in June, to help with weight gain. She was getting prepared for, her surgeries in the upcoming year. So we concentrated her formula to 70 calories per ounce, and she had no issues with tolerance or labs, which was great. So here are her growth charts now, since this is now her, 2 to 20 growth chart. She's doing great weight gain wise. Since then she's had her 2 major surgeries, so to correct her GI and GU malformations that was needed before transplant. And as of, I think, last month, she's active on the transplant list. So hopefully she'll get a kidney soon. And that's all
Yes,
from
and
me.
then can you tell us why she wasn't transplanted? Like, we come in as a 4-year-old.
So I guess she started as a 2-year-old. So our center doesn't transplant if they're below 10 kilos. And she didn't hit 10 kilos until 2020, like end of 2021. And then she needed 2 major surgeries before she was actively listed. So she ended up getting a colostomy that was then reversed. She had an anorectoplasty and then an ileal conduit done. So the last one was, I think, a few months ago. So now she's like fully ready to be active and like get the transplant.
Thank you.
Jessamine, well, we're waiting for audience questions to come in. I've got one for you. 1.1 grams per kilogram is pretty low protein for a PD patient. Do you think, maybe your opinion, do you think she needed to be dialyzed more?
I think that was one of the things that made us switch to like hemo dialysis. And also, it was very hard for us to get like an accurate like diet recall. And we see her frequently. Like at that point, we were seeing her like 1 to 2 times a month. So I think with all the lab changes, we assumed that like there was some non-compliance and,
Or was she eating a lot of high protein foods?
I didn't have like a good answer then, but now that she's in our hemodialysis unit, we can kind of see her eat when she's in dialysis. So I think yes, I would say yes now. She does.
I have one other question for you while we're waiting for any audience questions. Baby food at 4 years of age I wouldn't expect that. Do you have any thoughts on why she was still, did OT or speech recommend that, or were they using that?
So she
Because it looked
wasn't,
like she ate solids too.
yeah, she had solids too.
Other solids.
I think that was just like her preference, honestly. Like mom really tried pushing her to like eat more solid foods, but I think it was just easy for her and she was used to like the purees. From our speech therapist, she was cleared for like regular diet and thin liquids. And our she was in early intervention, which ends at you like graduate when you turn 3. So she turned 3 in 2022. So then she hasn't gotten any feeding therapy since. But she's, as of, the past year, she's not on like baby food. She's like just on solids, but on the low side. Like she still drinks a pretty good amount of formula.
So many good layers with this patient. Thank you. Okay, let's go ahead and take a question or two. Right now, I just want to share with you the VitaFlow Formula for Success program. I'm showing you this because Lisa's case, there definitely were some bumps in the road with getting the formula. So I just want to encourage you all. We know how difficult it is out there. We have the supports, we have our territory managers, and then please tap into this program. It can be very, very helpful. Okay, so we do have a question. This question is for Christina. It's from Laura. Christina, why did you start with Renvela and not a calcium-based binder?
Good question. I answered this in the chat, but I'll share my answer now. Our standard of practice at our facility is for adolescents to go on sevelamer. We typically supplement calcium separately, so we know exactly how much calcium they're getting, because when you use it as a binder, you don't always know how much is binding the phosphorus versus calcium supplements. So he had so many things going on, and his calcium levels were normal that that wasn't a focus. And I don't really know if the outpatient dietitian who followed him long term looked at calcium in his diet, which might have improved once he started eating better, to determine if he needed dietary calcium, since the Renastep is low in calcium. But if he had needed additional calcium, we probably would have given that separately. We just, for younger kids, for young children, we use calcium as a binder more, but we almost exclusively use sevelamer in our older kids. And I guess I should have mentioned that we felt okay using just Renastep as a supplement because he was by then eating more oral food, and so we weren't worried about potassium and chloride content of the Renastep because he was getting food too.
Okay. I actually don't see any questions. I just wanted to remind everyone in the chat, there is the PDF of today's slides. Just want to make sure we don't get any questions. I don't see any. So at this point, I just want to thank our panel of speakers. I'd like to also thank the audience for your participation. Polls were pretty fun. This is our last webinar of the year. So on behalf of VitaFlow, I just want to wish everyone a very safe and happy holiday season. We're going to start back up in January. We've got some good fiber webinars. So hopefully catch you all in the new year. Thank you.
Thanks, everyone.
Thanks, everybody.
Bye.